I want to bring to the podium now our next speaker, Dr. William McDade. Dr. McDade is the Chief Diversity, Equity, and Inclusion Officer at the ACGME, which is the Accreditation Council for Graduate Medical Education. He is an adjunct professor of anesthesiology at Rush Medical College. He received his MD and PhD in biophysics and theoretical biology from the University of Chicago's Pritzker School of Medicine. His internship was at the University of Chicago and residency at Mass General. He's had several leadership roles, including positions as the Executive Vice President and Chief Academic Officer at Ochsner Health System, as well as a Professor of Anesthesia and Critical Care at University of Chicago, Deputy Provost for Research and Minority Issues at the University of Chicago. He's also served on several boards, including ACGME, the Joint Commission, National Board of Medical Examiners, and also chaired the Task Force on Diversity and Graduate Medical Education. He's a member of AOA Honor Medical Society and also works with the National Medical Association, the Coalition of Physician Accountability, and the U.S. Department of Education. U.S. Department of Education. And Dr. McDade will talk to us today about why diversity, equity, and inclusion still matters now that DEI is out. So, Dr. McDade.
Well, thanks very much, Dr. Green, for inviting me here. It's a great honor to be present. Let me see if I can get my slides going. So I have no disclosures to report, except that I work for the ACGME. The ACGME is an organization that accredits all the core residency programs in the country, including the OBGYN, and many of the fellowships. And a few years ago, many of the OBGYN fellowships came into ACGME accreditation as well. So continuing the theme that Dr. Brown mentioned a few seconds ago on disparities, it's hard to believe it's been now over 20 years since this book has been published, Unequal Treatment. And it came after over a decade now of now having Medicare and Medicaid require that the race and ethnicity of all patients served is entered. When you have the data, now you can look and see whether there are disparities. And I remember when the announcement went out in 1992 to collect this mandatory requirement, if you wanted to get paid as a Medicare or Medicaid provider, that this was going to change what we knew about medicine at this point, and it certainly did. This was 600 pages that described disparities in a variety of areas. Our colleague Harold Freeman referred to excess mortality as the increased deaths that occurred in minoritized individuals as a function of the disparities that exist. Well, in the recommendations for this report from the Institute of Medicine, now National Academy of Medicine, it suggested that we increase the proportion of underrepresented U.S. racial and ethnic minority health professionals. And the rationale for this is, in fact, what I'm going to talk to you at the beginning of this talk about. Well, what's happened since then? Last summer, an updated publication of Unequal Treatment was actually published, and what it suggested is that we haven't made very much progress in that regard. That the percentage of black medical school graduates was 6.2% in 2019 and only 6.7% in 2023. We have to do something to increase diversity, is what the report actually said. Well, if you look at who takes care of people who are in underserved or marginalized communities, one of the best ways you can do it is to ask a first-year medical student, who are you going to take care of when you graduate? And this is what the AAMC does every year. And in their matriculating student questionnaire, matriculating student questionnaire, if you are black, it turns out you're about 60% or so, 64% likely to say that you're going to do this as a first-year medical student. If you're white or Asian, it's in the 20 percentiles. And so if you think about who constitutes the first-year class, about 80% of those individuals are white and Asian. And so that's the group that has the lowest propensity to care for underserved individuals. Now, 4 years later, we've had 4 years of a medical school curriculum that disabused people that the only people they need to take care of are the insured and wealthy. And what do we find? The numbers don't change at all. If you actually ask the question in a different way, let me go this way, of senior medical students, you say, well, are you going to serve the underserved? And you see the numbers there on the left-hand side of the screen in their communities. You get some answers, and it's about the same as the first years. But then if you can extend it a little bit and say, well, in your practice, wherever it is, are you going to still serve the underserved? And you still don't get very much higher. African-American students are around 68%, but white and Asian students just barely cracking 30%. If you look at this and say, well, that was just 1 year. That was a fluke year. Well, this is a several-year pattern, a 6-year pattern of the same question being asked, and you see very similar responses with respect to race and who's going to serve the underserved. So medical students, when they start medical school, know who they want to serve, and they continue that throughout their careers. This was data from the Cambridge Health Alliance that was published now almost over a decade ago, that suggests that if you're African American, you have about a 23 times fold rate of seeing a minoritized or black patient if you're a black physician. You've got a 19 times rate if you're a Latinx physician seeing a Latinx patient compared to a white physician. And if you're Asian, you're about 26 times as likely to see an Asian patient than a white physician. So this racial concordance that exists for blacks and Latinx and Asian people, it was a real thing and was documented there. Peter Bach studied this now over 20 years ago and saw that if you were a primary care physician, the chances of you taking care of a patient of your same race or ethnicity if you were a black physician compared to a white physician is almost 40-fold more likely. This data is just published a summer ago now, shows that if you have a black physician in your county, your life expectancy actually will increase. And that the poorer you are in one of those counties, the more your lifespan will increase if there's a black physician. That black physician doesn't even have to see you, as it turns out. It's just an association study. Another paper that actually suggested that there was an impact with concordance is this one. It comes from the National Bureau of Economic Research. Marcela Alsan is a healthcare economist and infectious disease specialist as well, who's at Harvard now, but she was out in Oakland along with my colleague Owen Garrick, who looked at this, where they actually set up practices of black physicians and white physicians, and they had black male patients from Oakland go to those physicians. And what they found is that, doing some very elegant mathematics in this paper, that you could reduce cardiovascular disease impact by almost 20%, just by having concordant relations between patient and physician, and you could reduce mortality by almost 10%, 9% here, if you had concordant relationships. And they felt that was due to diabetes screening, cholesterol screening, and invasive testing, all up 20% in the concordant relationships. This is a pre-COVID study, and they showed that even flu shots were more likely in concordant relationships. But the benefits of concordant care really address that unfortunate relationship of what we have with the United States and its people. The intention to adhere to medical advice is heightened, as well as the patient satisfaction scores among individuals who are cared for by a concordant care physician. There's improved clinical outcomes in some categories, but the bottom line is that it improves access to care to individuals who would rather forego care than to receive it in an environment that humiliates them, discriminates against them, dehumanizes them, and fails to communicate effectively with them. This is one of the points that Dr. Brown made a few minutes ago. So increasing the concordance or trying to achieve concordant care doesn't mean it's forcing people to work where they don't want to work. It's not limiting patient access only to concordant physicians. In fact, if the clinic were structured that way, I'd worry about it a little bit. It's not stopping patients from seeing the best physician, the most appropriate physician. And proximity is an important factor. You have to be in the community where the patients are. You have to have physicians who are willing to serve disadvantaged communities and accept governmental reimbursement. But patient choice also plays a role in this. So how does concordance operate? Well, there's improved communication, there's improved trust, there's greater experience with the culture of patients when concordant physicians potentially. There's increased compassion and urgency for underserved people. This is professional responsibility, race-conscious professional responsibility is actually described. There's increased patient access due to the minoritized physician's choice to practice in these communities. There's increased experience with disease phenomena in these communities by those physicians who work there, and increased experience in having to navigate with less and having access to provide access to the patients who are disadvantaged. My group has actually started to look at some data, comparing census data along with data from NPPES, and looked at the relationship between where people serve and their race and ethnicity and whom they serve. So if you look at the upper right-hand corner of African Americans, this is the group of physicians who serve non-Hispanic black populations by quartiles, the highest quartile being the far right. African American physicians are about 2.5 times as likely to serve those individuals in black communities. And this is based on census tract data and where physicians practice, looking at their Medicare billing numbers. If you look at who's more likely to care for poor individuals, you'll see the same thing, that African Americans are more likely above the bar than average to care for poor individuals. You'll see that Asian and white individuals are a little bit less, physicians are a little bit less likely. Hispanic individuals, Hispanic physicians, are more likely to care for underserved as well. But what are the alternatives to concordant care? Well, if concordance doesn't work, then we have to teach everybody how to care for the underserved. And that's an important thing. But how do we overcome the issue of trust when you have discordant care? How do we incentivize physicians who may not be from those communities or represent those communities to want to go there? We have to figure out how to incentivize this, but the wealth gap that exists in our country is such that there's no easy source of funds to support that. Well, how do you provide financial incentive to physicians who go to those communities and serve when there's no money in the community in order to do it? Secondary to segregation, few opportunities exist for transracial encounter. So how do you gain the cultural familiarity that you need in order to care for those people in the same way that a concordant physician might? What are the barriers that might exist that might prevent white and Asian medical students from wanting to go to those communities in the beginning? So there's stigma, there's safety, bias, underexposure, and appreciation of the community richness that exists. Many medical students using criteria that are based on test-taking skills in many situations and not on what they plan to do afterwards, which is to care for underserved individuals. And so how can we expect them to want to care for underserved individuals when we're not selecting students for that basis? So I didn't invent concordant care. If you think that I'm somehow pushing something that is unnatural, you have to go back to 1910. That's Abraham Flexner down at the bottom here. In his report that actually transformed the way medical education is delivered in the United States, has a chapter, it's chapter 14, on the medical education of the Negro. And what it says there, down in the bottom blue, that the Negro needs good schools rather than many schools, schools to which the more promising the race may be sent to receive a substantial education, in which hygiene rather than surgery, for example, is strongly accentuated. And if at the same time these men, these are men that you talked about, can be imbued with the missionary spirit so that they will look upon the diploma as a commission to serve their people humbly and devotedly. That's concordant care. So that's the definition of concordant care that's built into how we educate medical students in the United States. And what his concern was that there were 60 million white people in the country, 10 million black people in the country, and that if we didn't treat the black population, and we couldn't expect white doctors to take that responsibility on board, then they would serve as a source of contagion and disease and spread it to the rest of society. So we had to continue doing this. And he was a strong champion for the two historically black medical schools that we all know about after the closure of the other 5 schools at that time, Meharry and Howard. When I was a first-year medical student, Meharry and Howard are responsible for graduating 50% of all the black physicians in the country still. So it is not a legacy that is far removed. We are still living with that, and these institutions are still responsible for a lot of the medical education of African Americans. But we can't depend on concordant care to solve all the problems of healthcare disparities. There are those things on the right side of the screen that are referred to as the social or structural determinants of health. Our colleague Daniel Dawes, who's now leads the Global Health Center at Meharry, has a wonderful book called The Political Determinants of Health that recognize how inequitable policies, politics, regulations, and laws have impaired access to care and contribute to the health inequities. The other thing, and this is ACGME data that I'm showing you, is that we really haven't increased the number of green band people there. Those are African Americans who are in graduate medical education. We started collecting data in 2004, 2005 on this. Track it out, we've only gone up to about 5.8% now. The red bars are Hispanics. Those numbers have increased, and you'll see a little bit of gain right toward the end here. And it's only because we recategorized how we label Hispanics. Numbers gone up just incrementally as opposed to dramatically, as you see in a situation. So Melanie Tervalon and Jan Murray Garcia had a paper, that wonderful paper, that talked about cultural humility. And we really have to think about how we can suppress our own thoughts about how culture factors into the patient-physician encounter in order to lead patients to the best health care possible for them. And let me show you some data. This is a map that was very much like Dr. Brown's map, but this is our group that looked at the representation of black physicians in the country compared to the population of black people. So where the difference between the population number of black people is widest compared to the number of black physicians, or percentage of black physicians, what you'll see is the green circles. The blue circles are where there's more even matching, as it turns out. Low black populations and low black doctors gives you a blue, but high populations of blacks and low populations of doctors gives you a green. And you see there's a lot of concentration of green in the southeastern United States because the population of black people is larger there. But there were headwinds to diversity, equity, and inclusion before the inaugural. The inevitable historical backlash that's occurred because of the progress of civil rights movement in African Americans. There was a Supreme Court decision regarding race-based affirmative action. There was organized attacks on DEI by right-wing think tanks and individuals, expansion of state-level legislative efforts to repeal DEI training, including mission statements, resources, and hiring efforts. There was issuance of executive actions by state governors to eliminate DEI programs. There's the introduction of federal legislation to restrict DEI education, elimination of offices within medical schools, noting the roles of accreditors. And there were attempts to intimidate institutions and accreditors through hearings and finance. And what you see in that first wave is the Supreme Court decision of the Students for Fair Admission versus the Harvard and University of North Carolina. That's Ed Blum. He was the attorney for Abigail Fisher back in the Fisher case in 1915. And he started ginning up support for people who wanted to take down affirmative action by forming this group online, as a matter of fact, for Students for Fair Admissions. And they were successful. The outcome of that is that the 14th Amendment, according to the justices who wrote the affirming opinion, was that admissions programs at Harvard and UNC couldn't be reconciled with the guarantees of the Equal Protection Clause, and that there was lack of sufficient measurable objectives that warranted the use of race in these admissions processes, and there was a lack of meaningful endpoints. Now, I'll argue that the lack of a meaningful endpoint in medical school admissions is the elimination of health disparities, because there is such a strong correlation between who cares for whom in society. But Justice Roberts gave people an out, so they could say nothing in this opinion should be construed as prohibiting universities from considering an applicant's discussion of how race has affected his or her life. Now, that was written into the Justice Roberts' opinion. Justice Jackson, who you see on the left here, actually had a dissenting opinion, and one of her lines, which I think that should be a t-shirt, is deeming race irrelevant in law does not make it so in life. And I think we have to keep that in mind because the disparities are still there, even though now we're impacting the possibility of the workforce that's going to care for them. So what did the Supreme Court decision do? The year after the Supreme Court decision was put in place, if you look at the first year applicants to medical school, you'll see that African American applications actually went up by 2.8%. But in the fall of 2024, you'll see that African American enrollment went down 11.6%. 11.6%, right. Hispanic applications went up just slightly at 2.2%, and then Hispanic admissions and matriculants to medical school went down 10.8%. And these numbers were already low, and after that first year of the enactment of the Supreme Court decision, these numbers fell off even more. If you want to see the peak year of the number of applicants to medical school who are African American, you have to go back to COVID era in 21-22, where the maximum number of medical students ever who applied who were black was 6127. The number of people who matriculated that year was 2124. But every year since, that number has gone down. So the next year, the matriculants went down to 1855, then down to 1839, and now last year in the fall, 1627. Now, if you further subdivide the black responses into African, Afro-American, and Afro-Caribbean, and other black and more than one application, if you go further down, if you look at just the African American, these are people who are descended from formerly enslaved individuals. That number went down to 708 this past year in the entire country. 160 medical schools, 708 people. If you look at between male and female among African Americans, African American men represent only 269 people in medical school classes across the country. These are allopathic numbers. So the osteopathic numbers are even worse. So the point on this one is that we have already seen the initial impact of the Supreme Court decision. Now, there's a downstream consequence of the things that have happened. You'll note that undergraduate applicants have gone down to medical school. Medical school applicants will go down to residency because they're not going to have people who are there. And so if you look at what happens to the residency pool over the next 8 years, we're going to see those decreases that started this past fall impacting what happens in medical school. If you look at feeder institutions for African American students from medical school from colleges, what I show you here on the top line are the historically black colleges and universities where you see the enrollment, the application number went down in all of them this past year. If you look at the other top 50 schools that are feeder institutions for medical school, you'll see that all of them declined as well. And so the idea that we're seeing what's the foreshadowing of what's going to happen to us in graduate medical education right now is what I'm showing you. The fact is that there are a number of groups that have chosen to take on institutions of higher education to try to reduce or eliminate DEI efforts. In fact, the appointment of the EEOC chair, Andrea Lucas, who spent most of her career attacking DEI, she's now the EEOC chair, which means it might be even harder to try to advance things in the future. This is an interesting observation that we spent the last year and a half working on new standards for Office of Management and Budget's definition of collecting data on race and ethnicity. It was published in the Federal Register back in March of last year. It added a new category for Middle Eastern North African, and also abandoned the two-stage question of whether you're Hispanic or non-Hispanic in ethnicity, and it made being Hispanic a racial category, effectively, to be counted in that way, and established criteria for SOGI. But there's a group that's called the Cato Institute. They're on that list on the left side, and what they actually talk about is their playbook for executive actions, executive orders. And one of the things they talk about is that the collection of data in itself propels those groups that have been designated as disadvantaged with evidence to prove that they're disadvantaged. So we should stop collecting data. And in fact, they want to end collection of data at the federal level at the census, because it takes a longer time to figure out how to correct those problems if you don't have the data to do it, and the next group that comes in reinstates it has to collect data all the way from the beginning. DEI has become a dog whistle, because it really has not been well defined as to what it means and what people intend by it. So it's really hard to eliminate it. So people are starting to go through and take out words and try to end programs that they think may be associated with illegal DEI, which is what it's described as. But the fact is that there really is no clear definition for it. So when the president wrote the executive orders on January 20th, he said that we should end discrimination and illegal DEI. And we've been waiting for a good definition of what illegal DEI is ever since, but they didn't wait. They decided that they wanted to enforce illegal DEI even without a definition. So we've seen a number of activities over the course of the last several months since January. There were the executive orders ending wasteful government DEI programs and preferencing, restoring America's fighting force, which also addressed issues of race and ethnicity, leading to the takedown of some pages of people who won the Congressional Medal of Honor who were African American, as it turns out. There was House Bill 800 that the DEI to Die Act was introduced that parallels some of the executive orders that were signed. There was a Dear Colleague letter that was written on Valentine's Day that described activities that had to end at universities because they were illegal. And it listed a whole host of things that were related to the Supreme Court decision that had no bearing on college activities, only on college admissions processes, yet the government extended the idea to expand to other areas within campus life. Arkansas passed legislation in March that restricted the ability to give information to accreditors, as it turns out. Kentucky had similar legislation. Ohio passed legislation to end DEI offices there. There was a Department of Education letter that went to 60 universities that talked about their anti-Semitic discrimination and harassment that occurred on campus, and used that as a source of actually removing funding subsequently for contracts, federal contracts, and NIH grants. In April, there were another series of attacks to DEI. In May, the Educate Act that was introduced by Greg Murphy from North Carolina, which forbid having offices of diversity, equity, inclusion at medical schools, was introduced. More legislation in the state, revocation of NIH funding with DEI-related research. Over half the NIH funding that was revoked because it contained words that were associated with diversity, equity, inclusion, as it turns out. And then finally we get to May, where the executive order that then attacks creditors was actually put into play, where if you, actually it was in April that when that happened, when if you're an accreditor that you cannot, you should not have any requirements that require DEI. And then in July, there were the final straw to this was the introduction of the 2026 Hospital Outpatient Prospective Payment System Plan that was still open actually until the 15th of September for comment, in which it has a paragraph that says in GME that no creditor should be allowed to either require or encourage residency programs to increase diversity, equity, and inclusion. So that's the end of DEI at ACGME effectively. And so we have to figure out what we're going to do about this issue around health disparities if we don't have the workforce that will support it, and if we don't, and we're not able to educate on anything except health disparities. So that still is within the boundaries of what the federal government says you can do. That you can still teach that health disparities exist and help residents understand how to eliminate them. So I'm going to blow through this. This is eliminating DEI in the military that we just talked about. This is the presidential executive order that talked about discriminatory and illegal DEI that one was to be removed from all federal programs, and then they wanted to expand that to independent and private entities as well. This is the Dear Colleague letter that now expanded the Supreme Court decision to financial aid, scholarships, prizes, housing, discipline, and all other aspects of campus life, including graduations that were based on race and ethnicity or something. This was the letter to the 60 institutions warning them that the federal government would take action against their inability to protect Jewish students and fulfill their obligations under the Title VI provisions of the Supreme Court decision. This was Trump's secret weapon where he went after accreditors. He went after the American Bar Association, which accredits law schools, all the undergraduate institutional accreditors, and the ACGME was listed, the LCME was listed as well. Those are the accreditors that were targets of that particular executive order. And what it says for in the executive order is that the Secretary of Education, as appropriate and consistent with applicable law, shall hold accountable through denial, monitoring, suspension, and termination of accreditation recognition accreditors who fail to meet the applicable recognition criteria and otherwise violate federal law by requiring institutions to seeking accreditation to engage in unlawful discrimination and accredited related activity under the guise of DEI initiatives. It was very interesting. So this put us on warning that things could happen, even though we are actually under the Secretary of Health and Human Services and not the Secretary of Education at ACGME. What the Arkansas bill did, since you can't give data to accreditors, now the LCME, the organization that accredits allopathic medical schools, which had a requirement, standard 3.3, which said that medical schools have to have effective policies and practices, engage in an ongoing systematic focused recruitment and retention activity to achieve mission-appropriate diversity outcomes among its students, faculty, and staff. We had a parallel requirement at ACGME that we started about a decade later, as it turns out, our program requirement 1C, now 1.7. What you see after the implementation of 1.7, which is right here in 2019, that the number of African American students actually went up, as it turns out. So it was effective in part, or at least by association, with an increase. Now you could say, well, the number was increasing before then, and this is a continuation of that, and I gotta say yes. But what you have to see is that the green bars in that plot that I was showing you didn't really increase very much at all, and this is looking like it's significant progress. If you look at different specialties and what happened since the implementation of program requirement 1.7, what you'll see is that there's the break mark from blue to green, and that the number of African American students, residents, actually has gone up in a number of specialties. And these are the things that we were concerned about, that in fact, that there may be a fixed number of fourth-year medical students who are underrepresented, but they were almost completely excluded from some specialties, and they were very poorly represented in others. I look at ophthalmology as an example of one where we had significant progress, in which when I started in 2019, before the implementation of 1C, or 1.7, there are only 34 ophthalmology residents in all of graduate medical education in all programs. They started with the Academy of Ophthalmology, Minority Ophthalmology Mentoring Program, MOM. We actually recognized them for the achievements that they'd gotten underway, although very modest, but the program was very interesting. And now, 5 years later, that number's gone from 34 in the entire country up to 89. And it's exciting to see the progress that you can make in certain specialties when there is an impetus to do this. OBGYN, you can see the numbers have gone up there. As a matter of fact, that's the shaded red box there. And one of the other interesting things that you're able to look at, and this is obstetrics and gynecology on this rung, is that these are the number of programs that actually train Black residents. So if you look at the percentiles of programs that train 50% of all the Black residents in the country, it's only about 13.5% of programs. And if you look at the number of programs that don't have a single Black resident in all 4 years of training, the fact is that that represents still about a quarter of the programs in OBGYN. So the fact is that there's a lot of progress that could be made if we had more people in programs where they don't have very much representation now. And it shows you the fragility of programs that have a large number of trainees, and I'll show you the exact data for OBGYN in a second. But the fact is that if one of those programs goes down, like the OBGYN program at Meharry, for instance, then it has a greater impact overall in the number of African Americans who are trained in the field. This is the Arkansas bill that said you can't give information to accreditors for collection and reporting purposes, and you can't comply with any institutional accreditation requirement, an accrediting agency that would require state-supported institution of higher education to violate the law saying you can't engage in DEI activities. And so with respect to that, the LCME dropped its standard 3.3. So it is no longer a requirement in undergraduate medical education allopathic to work to try to increase diversity as one of the missions. So the ACGME Executive Board met about a month after this actually had happened, and we looked at our statement and we said what we're going to do, because the pressure is so high, is we're going to actually suspend enforcement of our Common Program Requirement 1C, the parallel one to 3.3. And so that's the condition that we were in up until that CMS OPPS proposed rule change occurred, which says that you can't require or encourage residency programs to do this. And so our board is going to meet in about a week or so to determine whether we should actually remove the requirement or whether we'll just keep it as it stands right now as unenforced. It's a dangerous time in education in general. And I will say that the ACGME hung in there for about as long as it could in order to try to address the issues of health disparities. But you have to realize it's the single accreditor of the United States. And that as the single accreditor, one of the things it is concerned about is whether other accreditors will enter the market if they don't recognize these sorts of things. And then there's also the possibility that there could be delinkage of funding between graduate medical education accreditation and graduate medical education funding. One of the drivers for seeking accreditation is one, to be able to say that you have very high standards and to be able to have your residents sit for their board exams because those are required. But the other thing that drives you is the money involved, that you qualify for Medicare supplementation of your graduate medical education programs if you are accredited by ACGME. And that's a lot of money for many institutions that they could not forego. And so the choice of being accredited by the ACGME really is a non-choice for programs that seek funding from the federal government for their residency programs. This was the first line of attack against the ACGME, which was trying to implicate it as in conspiracy or collusion with NRMP and limiting the number of physicians produced. But data shows that the number of physicians have increased over the last decade dramatically. And so I don't know how you make the argument, but they still had a congressional hearing with the House Senate Judiciary Committee driving it, and they used it as a means to really point out some of the issues that they wanted to bring to the fore. This is that OPPS rule, which says that accreditors may not require or otherwise encourage institutions to put in place DEI programs that encourage unlawful discrimination on the basis of race or other violations of federal law, and that the secretary may certify other organizations as accreditors. So that's the thing that said, okay, we've got to stop doing this and figure out how to do other work that's going to be effective in helping to advance the health of the American population. So let's look at the numbers from OBGYN. If you look at where OBGYN is with respect to the percentage of African American residents over the last 10 years, it's number 2. You've done a very good job in increasing by percentage the number of African Americans in the specialty. If you look at the past year, you're still just number 3, and that's fantastic for what you've been doing as an organization. If you look at all the residents in all the core specialties, this is a 10-year run of that thing I just showed you where the green bands are African Americans and the red bands are Hispanics. You'll see that the numbers have increased just slightly, but they've increased. Let's see what happens in OBGYN. Percentage of OBGYN individuals 10 years ago was about 9.2%, and now it's up for African Americans to 10.1%. So that's modest progress at best, but progress. If you look at the numbers of individuals, there are now 615 residents in obstetrics and gynecology across the country, up from 480 10 years ago. The Latinx numbers are up as well. If you break that down by gender, where the darker color is at the bottom of the 2 consecutive colors, so the dark blue at the very bottom is white women, these are white men, these are Asian women, these are Asian men. Asian men haven't changed a bit over the last decade, as it turns out. Hispanic women have increased slightly. Hispanic men have increased more by percentage. African American women have increased since 10 years ago. African American men are staying pretty flat. In fact, it's about as low as it's been over the last several years in terms of African American men. Let's blow that up. And what you'll see is the African American numbers in green, again, Hispanic numbers in red. African American men still represent a very small fraction of the OBGYN population here. Women have increased slightly over the last 10 years. If you look at who's actually gone to where the extra seats in OBGYN residency programs have gone, you'll see that white women have been the greatest beneficiaries of those, followed by Asian women, and black women have made little progress, but some, and as well as Hispanic individuals. If you look at black men, you can see that that number is pretty flat. Over the last decade, black women went down and then it now started to come back up. This corresponds to the implementation of Program Requirement 1.7. Now, this is the data on OBGYN programs in the country. So again, I told you 615 black residents in 4 years of training. There are 295 OBGYN programs in the country. 50% of all African Americans are cared for at 13.6% of programs. That, in fact, 99 programs, 33.6%, don't have a single black resident in all 4 years. And if you look at the programs that have the greatest number of African Americans, there's 2 programs that have 14. There's one that has 13. Another couple have 12. And you'll see the numbers get down to the onesies, twosies that are the largest number of the program. So we've got a lot of work to do to try to spread diversity throughout the training environment for OBGYN, but it is better, as I said, as you saw, than many other specialties. People are also concerned about people leaving residency, and this is where I think we have to put increased emphasis. Since entry into residency program is going to be blocked by the number of applicants that we have and the reductions that have occurred because of the Supreme Court, one of the things that you can do is keep all the residents that you have. And yet when we look at the people who have left OBGYN who are African American, you see that number is pretty big over a 10-year period. And so we have to think about the idea that there are many-fold times residents who are white in OBGYN, and the numbers are relatively, are not proportionate, as it turns out. If you are dismissed from an OBGYN program and you're African American, that is probably the highest likelihood of any group by race who's been dismissed by percentage. Compare that 25 to 40 individuals. And the number of whites who are in OBGYN is much, much larger than the number of blacks who are in OBGYN. We can't lose any. The ones who are withdrawn from their programs is also higher for African Americans here at 55 compared to 157. So again, we're losing people in that regard. And so what I would encourage you is that we develop individualized learning plans for all of our residents in OBGYN. That's an ACGME requirement. That's going to still stand. We also have to figure out what it is in our environments that it's making it so tough for people to be able to be successful there and to try to reduce as many barriers as we can to success. These are the individuals who transfer. That number is not very large, as it turns out, for African Americans and Hispanics. One of the things we did was we looked at the number of first-year residents who were admitted to classes in OBGYN the year after the Supreme Court, because what we were concerned is that some residency programs might view the Supreme Court decision, which is a Title VI higher education decision, as applicable to their residency program, which is a Title VII hiring issue. And by the misapplication of that, you could expect that resident numbers might go down. But what you see in OBGYN is that the resident numbers stayed about the same or went up slightly in that situation. So there was not much of an impact of the Supreme Court decision of what happened in that first year after the Supreme Court decision to resident hiring. So what you have to remember is that we still need to achieve health equity because there are still massive health disparities that exist in the maternal and obstetrical care. You know that firsthand. We have to educate and inform ourselves about the laws and what constitutes illegal DEI and avoid those activities and actions. So you want to be consistent with the law. And when public comment when public comment periods exist to change requirements, provide written testimony on how those changes might actually impact the patients that you care for, the learners that you educate. And many of these legal issues will ultimately have to be decided by the judiciary. There was a decision just yesterday, as a matter of fact, on this. The most pressing ruling is what constitutes illegal DEI and discrimination, because that's such a nebulous concept. I don't think anybody who had a DEI program got away from talking to their lawyers beforehand and always did things within the binds or the confines of what legal DEI was. So the idea of illegal DEI has to be defined in a way that still helps you to figure out how you can encourage people who are more likely to serve the underserved to come into medicine. Now, if you look at the numbers of people who you see represented in media, these are television programs and a couple of movies that have black doctors. And because of the wide representation of people, you'd say to yourself, wow, we must have lots of black doctors out there. And as you see, the data would suggest otherwise. And for all of you who are trying to figure out who people are, that's who they are. So there was an underinvestment in education and the persistent wealth gap that already adversely impacted the number of blacks trained in medicine. If you look at the US Supreme Court decision, and it's now lowering of the individuals who are admitted to medical school and college, that's another barrier. If you look at states that have enacted these laws to restrict DEI practice and close offices that support black students, another issue. If you look at President Trump's executive orders to reinforce merit and eliminate DEI and referring to DEI as immoral and illegal, that's another blow. If you look at the DOJ's attempts to extend the Supreme Court decision to apply to multiple areas of campus life, yet another blow. If you look at the executive order to restrict accreditors from requiring institutions to engage in DEI activities, another blow. States that restrict the ability to get information to accreditors and causing the LCME to drop its standards, yet another. The federal government eliminating NIH funding to promote diversity, withholding current funding from investigators who study subject with DEI-related terms, another problem. If you look at executive orders that restrict race balancing, Title VII issues, and disparate impact analysis, yet another blow. And then you look at the big, beautiful bill, which was passed on July 4th, where there are limits on the amount of borrowing that a graduate student can obtain. So the max is $50,000 a year, you get 4 years of it, $200,000 total. If you look at what the average borrowing is for African American students who are in medical school, it is over $200,000 a year. And so people who can't afford a medical education, who use federal funds to pay for it, are now going to have to try to get commercial loans. I don't know how many of you dealt with the HEAL loans back in the early 1980s, but those were very high interest rate loans that it took people a career to pay back. Now we've got the CMS proposal of OPPS that bans are encouraging or enforcing or encouraging DEI in programs. And what that means is our wonderful program that we started a few years ago, ACGME Equity Matters, to give people strategies about that, is now going to come down off of our website. So the future is rather foreboding, as it turns out, if you're an African American who is in medicine, if you're trying to figure out how to care for African American populations subsequently. And we really have to look at the future. We have to make sure that ACGME reinforces the idea that only lawful behavior in all circumstances should be engaged in residency. We're not telling you to rebuke the federal government. We're saying do what the federal government tells you to do. We think that education and the elimination of health disparities is essential, though, for all residents. That was part of the CLEAR program, And you may not have seen the announcement, but the CLEAR program is now going to be discontinued as well. We're going to treat health disparities as a medical quality problem and educate through systems-based practice and practice-based learning ways to improve the health disparities to prepare physicians who practice in this country. And we're going to redefine merit in terms that transcend mere testing and speak also to the societal role that physicians will play after graduation. So these are the things that we're doing at ACGME, and thank you very much for your time and attention.
Thank you. So I'm sure many of you may have some questions, so please come to the microphone and ask your questions.
Thank you, Dr. McDade, for that talk. I'm Teresa Bird. I am Program Director at Wellstar Kennestone in Atlanta, and this is something that's near and dear to my heart, so I appreciate all the data. One statement I have is just, looking at this is very painstaking to me because, thinking about this, training residents for my entire career, looking at this data just lets me see how fragile our state is, and that if we don't do something to change these laws, people like me, like Dr. Brown, like you, are not going to exist in the future. And we're really seeing the dumbing down of America and the dumbing down of medicine. And if you think about it, look at RFK Jr., that's what your medical institutions and your hospitals will look like very soon if we allow this to continue. So with that, is there anything in the way of that maybe the ACGM is doing, maybe they can't, or any entity that is looking at potential help with us? Like, what can we do on the ground other than what you gave us here as far as legislation? Because if we are voting for things that are, shooting ourselves in the foot, then we're more of the problem. So is there something that we can do that even maybe if you voted for this current administration, that you could now kind of right your wrongs by saying, okay, now I'm gonna, vote for this instead? Is there anything or any body that is maybe legal body that is helping to guide people to help go against some of these things that are being instituted?
Well, thank you, Dr. Bird, for your comments. The ACGME doesn't take political positions on things, and I can't advise you what to do with your vote. I will tell you that the state's attorney generals in Democratic states have actually waged a number of attacks against issues that have come forward. So, for instance, when NIH dollars were withheld from institutions, many of those attorney generals came together, and that was reversed, and some funding was restored. So that's an initial sort of volley at some of these, but the judiciary is going to have to make decisions on almost all of these things. And I would hope that people keep in their minds, in the training circumstance, that it is our responsibility to ensure that we eliminate health disparities and educate all of our physicians to understand that elimination of health disparities is essential to the betterment of care of individuals. We spend probably $1 billion a year in terms of the medical care and the loss of productivity of individuals who suffer from health disparities. And I think it's in everybody's interest to do so.
Thank you.
Thanks, Doc. Again, we've been in this together, and we're actually in Chicago talking about this a couple of years ago. And of course, here we are. I just received actually an email from my medical school from Wake Forest, because about a decade ago we started what we call the Gordon Watt Scholarship Fund. And the money was primarily raised by alumni from Black alumni. And so I knew we were going to get the letter, because the way that the creed was initially written was that we had preference to giving the scholarship to minority students. Well, of course, the legal people said, well, you really got to change it. Either eliminate that altogether or change the language. So we literally changed the language, as we've done, to say socioeconomically disadvantaged students. Now, if you go by that, in reality, that encompasses a lot of students. And so we're having to rewrite things. And we have $500,000 that's been raised by us to give. And so all schools are having to do that and challenge that, to not violate, quote, Title VI, Title whatever. So as we revamp languages, and I'll get back to your questions, we have you know, you're not gonna. I say I'm never gonna sell my soul to the devil, and I don't intend to order to achieve the objectives that we need to have. And health equity and health disparities are with us. And we're not going to eliminate that map that we see out there that I showed you all about rural obstetric care and all those kind of things, because the reality is we have to keep going. We have to keep encouraging. And I would say that one of the things that we did, even in Florida, with all the challenges that are going on, is that we recodified our pathway programs. Many of these are now foundation funded. They're funded by philanthropy as opposed to being funded by the state. And I say we have to get dollars out there for these programs, whether we're engaging in pathway programs in high schools or in colleges or elementary school. We have to do it. So
I agree with you that pathway programs are important. And if you looked at our ACGME Equity Matters Resource Collection, 1/6 of it was designed to try to increase pathways. And the way that I actually would have interpreted 1.7 is to say, a residency program doesn't need to increase the diversity in itself, but if it's working in the pathway to graduate medical education, anywhere along the pathway, I would have said you're in substantial compliance with 1.7. And so, now that that's gone, will there be the impetus to continue that sort of work? I don't know, and I certainly can't encourage you to do it anymore because I'm an ACGME accreditor. So you're going to have to understand that this is the way that you're going to have to approach this problem, because you can't generate fourth-year medical students out of a whole cloth. The process starts someplace before 8th grade. If you haven't had 8th grade in algebra by 8th grade, chances are you will not be a successful college graduate in a scientific STEM field. And so we need to figure out how to reach earlier learners, how to keep all the people that we can within the pathway to medicine, and to try to do the best we can from whatever vantage point you can legally. So,
Cyril Span, Atlanta, Georgia. One of your slides had a data about dismissal of residents. I think you mentioned 40 African American residents were dismissed. Why were they
25.
dismissed? 25. Why were they dismissed?
we don't get information typically on why. There can be personal factors, it could be academic factors, it could be all sorts of reasons, professional factors. So we get a little checkbox that says it was for professional reasons or for family, personal reasons.
Thank you for that great discussion. I had a question and then a comment, but you sort of made my comment. So my question is on the one graph that you talked about applicants, not matriculation, but applicants. The applicant numbers seem to be down across the board. And I guess my question is, what's happening in colleges that's decreasing the interest in medicine? And then I would get back to the other comment you made, which I completely agree with, which is if we don't get kids engaged in education at very, very early years. I served on a school board in my town for 12 years, and you could determine pathways from a very, very early age of where people are going to be. And I think it's incumbent upon us, if we want to engage more people in education and medicine, getting involved in local school politics is actually a way to engage people and understand what medicine is about. So I would encourage you all. And we used to, when I was a medical student, had tons of programs where we had medical students going into high schools and doing STEM projects. And I don't know if those exist to the same extent. And the AMA had a lot of funds and programs. But I feel like there was an excitement around it many, many years ago. And that doesn't seem to be the same way. Maybe I just don't see it. But we've seemed to lost that interest.
Well, when I was chair of the Minority Affairs Consortium at the AMA, one of our residents from South Carolina, Sheila Roundtree, actually suggested that we start a program that we call the Doctors Back to School program, which is a way to try to bring doctors into schools at grassroots level that the AMA supported for a very long time. And it's still going in some places, as a matter of fact. I will tell you, I operate maybe 1 or 2 days a week at Rush, and I had the greatest pleasure of all when I saw that one day I was scheduled to staff as the anesthesiologist the case of a young OBGYN who was in one of my summer programs as a high school student, as it turns out, at the University of Chicago. And she didn't know that I was going to staff her case, and when I walked in the operating room, it was like, it was tears. It was fantastic to see someone who I met when they were 13, now as an attending physician doing a case in OB, or doing a case in GYN. And so I say to you that it's still important to do those pathway programs. Yeah, how you get funding for them is going to be tricky. I know Burroughs Welcome has lots of grants that are interested in that sort of thing. But you know, the fact is that when you're restricted by what you can do by your institution, it may be hard for institutions to even involve themselves when the money comes from the outside, because you're engaging the activity and you receive federal funds. And so there's that line there that is very unclear. Last one?
This is Dr. Al Scott, past president of GOGS. What is the impact of board certification on getting residents out in the community?
Well, so I don't really speak for ABMS, and I don't have their data to describe what happens to people when they finish their residency training. We send them information. They send us information at ACGME. I haven't specifically looked at the problem of inability of people being board certified. Is that a problem for OBGyn?
Yes, I've heard, I've spoke to a number of physicians that have had difficulty getting past the oral boards. And I'm wondering if that just, I've not seen any numbers with regards to that, and I'm just wondering if maybe Dr. Brown is mumbling something, he can come up and say something.
If somebody has better numbers than I do, please.
Yes, I fail people.
No doubt.
No doubt about it. But I'm kinder and gentler. I think the challenges of failing your oral boards is really not anything other than being prepared for the exam. Because it's the easiest exam that I've ever given now because it's so sterile. People taking the exam are really taking it on their chief resident cases because they haven't done any vaginal hysterectomies anyway. I started giving the exam in office practice a few years ago because Dr. Drogmiller said, do office practice because, you know, OB, you can do that. And I used to say, if a candidate didn't know more office practice than I did, you know, they fail. But most people, I would say the numbers are really not, I don't think, discriminatory at all, because most people ultimately pass the exam. The reason you have to pass your exam is because you're not going to have any hospital credentials if you don't. And so I've tutored people, I've worked with people, and it's a challenge even in MFM. But the reality is, I don't think the numbers are discriminatory. I think it's preparation. I failed some people. And it's hard for me to fail people.
But you've looked at comparative numbers
Absolutely.
over the years.
We have the data.
And the point is fairness of it. That's
Absolutely.
That the comments made, fairness of that.
Right. We have more examiners of color of all races, and women, and so forth and so on, at the American board than I've ever seen. And I think the reality is that it is about preparation. People get nervous, you know. Or you're just doing some crazy stuff. And then anything to do with what color you are. I told a guy once, he said, I was examining a guy, and I said, you can really do that? And he said, oh yeah. I said, okay.
Thanks.
So on Dr. Brown's end of his story, we'll go ahead and end the session. Thank you so much to Dr. McDade for that really insightful topic and exceptional information. We now have an opportunity